Yeah, my name does sound a little bit like a disease. It's interesting. I was thinking about a story. Thank you. I was thinking about a story with Steve Jobs when he first invented the Macintosh, or first was commercializing the Macintosh. He went on the speaking tour over Europe, and he had a chauffeur kind of driving him around Europe, and he was introducing the Macintosh, and he did it in like 20 cities in Europe, and over again, the same presentation every single night. And he had this chauffeur that was driving him around, kind of doing the thing. And, he was kind of a contrarian and playful, and he's talking to his chauffeur, and he was saying, I'm so sick of doing this presentation. You've seen me do this presentation 19 times before. Why don't we switch clothes? You put on the jeans and the black T-shirt, and you get up and you give the presentation. No one will know. And he's like, no, I don't want to do it. But he talked him into it, and finally the chauffeur gets up and starts going through the presentation, slide after slide, and talking about the Macintosh and everything and how good it went, how good it is. And the crowd loved it. They thought that it was a perfect presentation. And then at the end, he started taking questions from the audience. So the chauffeur had heard most of the questions before, so people were asking questions, and the chauffeur was answering them and just kind of getting it perfectly. And then one guy in the back of the room kind of raises his hand, and he's like, well, what do you think the socioeconomic implications of the Macintosh are going to be 20 years from now? And the chauffeur had never heard the question before. And the chauffeur's kind of sweating now and not sure what he's going to say. And he looks at the guy and he's like, I'm surprised by that question, because that's the stupidest question that I've ever heard in my life. And he goes, it's such a stupid question, I'm going to have my chauffeur answer it in the back. So the point of the story is I'm just a chauffeur. And, there's a lot of people that work on telehealth and digital health in our organization. And really, I'm just kind of communicating it. And I listen to the presentations in the morning, and they're fantastic. They're truly the future of where digital health is going. Right? And then I think of the things that we're doing at UC California, UC San Diego, and I feel like we're in the dark ages. We still have a long way to go, but it's only by really understanding exactly where you are, what your current frame of reference is, what the current state is, that you can really make a path that will take you to the future. So I'm going to talk a little bit about where we are today and kind of the practical realities of telehealth at UC San Diego. So I wanted to talk about academic medical centers in general. Academic medical centers are a special breed. The fundamental goals of telemedicine in our organization and kind of how that complements and contrasts with the goals and objectives of academic medical centers. What the real indirect cost opportunity is for us, just on a macro basis, how much money is in it for us, why we need Medicare reform and why that's really limiting our adoption of a lot of digital technology, and what are some of the critical aspects of designing a successful program, and what does our program look like at UC San Diego. So academic medical centers all have this tripartite mission. We're combining patient care, teaching, and research, and we really focused on high quality, being mission-driven. We focus on the really nasty stuff that nobody else wants to do, brain surgery, heart transplants, stuff like that. We're really working on the most critical advanced care options. And we traditionally are very payer and payer mix agnostic. We treat everybody, from the patients that are have the Uber Cadillac insurance plans to the patients that are on Medi-Cal that have nothing. On the other side, so those are all great things about academic medical centers. On the other side, there's a lot of inertia. We tend to be very consensus-driven organizations, and that takes time. And when you work in the startup world and you go to an academic medical center, it seems like you're sucking molasses through a paper straw. You just can't get it to go fast enough. They also tend to be a little bit territorial and a little bit siloed. A lot of faculty in academic medical centers live and die by their grant funding, right? And so they tend to be a little bit territorial about the money that they have and how much they want to share their world with other people. So that sometimes, creates an opposite effect. If you look at what goes on in telemedicine, telemedicine on the good side, improved access, reduced costs, better experience for all the patients. But on the other side, It also has the potential to reduce the territorial dependence. It's silo agnostic. It creates a little bit of a loss of control for some of these people. So what you end up doing is you challenge some of the fundamental tenets within an academic medical center. So you need to be careful how you position it. On a macro basis, for what virtual and digital health means to us, if you take a look at the cost of an in-person visit for us, it's about $375. We get $92 in reimbursement, so we lose about $280 every time you go see your primary care doc. If you take a look at the video visit, we get almost as much money in a video visit from a commercial payer. So our margin or our loss is a lot less. So there's actually a $100 savings for us every time we do a virtual visit. So if you take a look at the 1 million visits that we do every year just in San Diego, and you assume that you're going to move 10% of those to virtual, 10% of primary care, 5% of specialty care, that comes out to 133,000 visits, right? $100 times 133,000 visits, it's $14 million a year for our healthcare system. It's a really big number. And that's the thing that kind of gets the attention of our hospital administration. That's the thing that gets the attention of the people within our healthcare system. Now, one of the big challenges that we have is Medicare. The demand for virtual health is taking off, right? Everybody wants it, the patients want it. It's really a kind of a viable technology. At the same time, Medicare is not reimbursing or is reimbursing very, very poorly. They have eligibility criteria where they limit it to just real-time visits, so you can't do asynchronous visits. There's limited geographies, limited origins of care. I work in a city called El Centro sometimes, right? And does anybody know El Centro? El Centro is on the border right between California and Mexico, halfway between the coast and Arizona. It's virtually the middle of nowhere. And it doesn't qualify for virtual visits because they don't call it a rural area. Now, anybody that has been to El Centro knows this is a rural area and they need telemedicine there. But the point is the Medicare laws need to be updated and they're antiquated. The 2019 reforms in Medicare, they're moving in the right direction, but they're largely underpowered. So access is still really limited in Medicare. Within our organization, we have a very consensus-driven organization. We have a steering committee, we have an executive steering committee, and then we have work streams that kind of implement the telemedicine within our organization. Because it's a consensus-driven organization, when you're positioning in technology, you need to really be looking at that lower group, the director, the medical director, the information services compliance, all of those functions are going to have a say in whether or not the technology gets accepted. This is the key point. When you're looking at the adoption of technology, there's a technology adoption curve. There's some people that are way out on the bleeding edge, and there's other people that are really conservative. And the bleeding edge stuff is riskier. So depending on how much money you have to invest in an organization, that will determine where on the curve you operate. So if you have a lot of money to invest in new technologies, you can afford to build a big portfolio knowing that a lot of them are going to fail because you have enough money to invest in a really large portfolio. On the other hand, if your organization doesn't have a lot of money to invest in new technology, you're going to need to be operating way over on the left, right? You can't afford to make a portfolio big enough to mitigate the risks associated with kind of cutting edge technologies. So when you go into a hospital and when you're positioning a new technology for adoption within the hospital, you need to understand where the hospital is on that technology risk. You can't go in presenting a technology that's 10 years in the future to a hospital like El Centro that doesn't have a lot of money to invest, right? They need to match their investment criteria with the amount of capital that they have to build their portfolio. Within UC San Diego, we do telehealth kind of across the board from provider to provider to patient to provider to consumer. I won't go through all of the specific details, but we have a pretty broad portfolio of telesolutions that we drive out. We try to focus our stuff on kind of core technologies, but we invest in some growth technologies and also some managed care because the hospital technology is moving much more towards managed care. And in conclusion, academic medical centers are challenging. They're unique. They have a commitment to multiple things, but it sometimes mitigates their adoption of new technologies, but they're fundamentally a great testing ground for bringing new technologies to market. The fundamental tenets that telemedicine can reduce costs are paramount in today's medical arena. We need lower cost ways of providing medical care. And the three most significant elements of a sustainable telehealth program are governance, matching the investment needs with the risk tolerance of the organization, and then maintaining a balanced portfolio. So thank you very much.
Hello. Yes. As a psychiatrist who had to leave a quote-unquote cutting-edge academic institution to actually do anything, I look in here, it's different in different institutions. In Mon, University of Wisconsin, you have restrictive covenants, so anything we do, even though you're only paid on production, so I'm not paid for my time or anything like that, but anything you do outside of that or any innovation you try and do within your own office is all of a sudden owned by the institution. Do you have those in your place, or do you have other ways to try and incentivize
We do,
your physicians?
although there are ways to carve it out. So there's unrestricted time that you have as an academician where you can start to work on things that are independent. Where you need to be super careful is with the area of intellectual property. If you develop technologies, if there's intellectual property associated, the university is always going to say, we own that intellectual property. So typically what people do is if they're working on something new, they'll negotiate a license for any intellectual property that gets developed early on in the process. And typically what the university wants is a percentage of revenues in the long term, and it's usually kind of 3 to 5%, something like that.
So, sorry.
Yeah, I think you're on.
Okay, yeah.
Oh, sorry.
Sorry about that. So for example, like typical doctor get paid in telemedicine about $20 to $30 a visit. I was surprised your cost structure was so high.
That was private insurance. Okay. So that's the Aetnas, the Uniteds. Well, private insurance companies recognize the value in telemedicine, and they pay for it almost at the same level or at exactly the same level as an in-person visit. The $20, that's Medicare. That's. But
I was thinking for your internal costs, you were showing a couple $100 per. Where's that cost come from?
Bricks and mortar, largely.
Okay.
Buildings, air conditioning, utilities, stuff like that. We don't necessarily need to invest in quite as much with a virtual visit.
Okay. Brad Dreyfus, University of Arizona and Banner Health. So in the context of what's happening with academic medicine and training being bought by these hospital groups,
yeah,
moving away from academia, what are your insights with regard to the kind of traditional academically driven telehealth and then our health systems telehealth? Because there's total mismatch in sets of priorities, and I think the framing of risk tolerance is also important in impact.
If you don't mind terribly, I'd like to take that question. Let's you and I talk about it because I'm not sure I fully understand the question, but I'm sure that I would like to comment on it.
Joe McMahon, I'm a health lawyer. I know of only a couple of academic centers that have formal fellowship trainings in telemedicine.
Yeah.
I'm curious, do you anticipate that we'll see more of that in the future or not? And if we're not going to see that, why not?
I mean, we have a huge teaching mission and tons of fellows. We don't have a formal telemedicine fellowship program, although a lot of our fellows are working in areas that have large telecomponents. And what they end up doing as part of their fellowship, they will integrate a lot of telehealth into the studies that they do. So it's kind of a little of both, nothing formal, but quite a bit out there for the fellows.
Time for one more. Awesome. You mentioned the need for reimbursements to catch up for telemedicine. Mm-hmm. Is there any reason to then consider cash direct payments for that as an alternative model as the market catches up?
And we do. One of the growth strategies that we have is TeleExpress Care, and we try to use TeleExpress Care for that. And I know there was an earlier comments about it's hard for TeleExpress Care to actually ever make money. But we see it as a growth vehicle. It brings people into our health system. And we have a opening screen on a Express Care visit that says, you know, we'll use your insurance, but if not, then we want you to pay in cash. And people do, and it's $50, so I mean, it's pretty reasonable.
Thank you so much.